thank you, Rick and Steve and Miguel, for the invitation to speak. And thank you, Doug and Adam, for moderating. So we'll be talking about the use of endoscopy to evaluate esophageal, gastric, and duodenal Crohn's disease. And we'll first begin just talking about upper GI Crohn's disease overall. So it was actually first reported in 1937 in the duodenum by Gottlieb and Alpert. It's a relatively rare condition with a prevalence of Crohn's disease proximal to the ileum of anywhere between 0.5% to 16%. Most patients, the overwhelming majority, will have coexisting distal Crohn's disease. And in fact, isolated upper GI Crohn's disease is even more rare, with accounting for maybe less than 10% of the cases of upper GI Crohn's disease overall. It has a slight male predominance, tends to be diagnosed younger than distal disease in both adults and children, and is associated with less smoking. So you're all familiar with the Crohn's disease location classification, L1 in the terminal ileum only, L2 in the colon only, L3 in the terminal ileum and colon, and L4 in the Vienna criteria from 1998 was proximal to the terminal ileum only. And in the Montreal criteria in 2005 was revised to include proximal to the terminal ileum with or without coexisting L1 to L3 disease. But let's delve a little bit more deeper into L4. So historically, upper GI Crohn's disease has been considered more of an aggressive phenotype with a higher risk of stricturing and penetrating disease, higher need for surgery and hospitalization. But this is a recent analysis. It's a cross-sectional study from the NIDDK's IBD Genetics Consortium headed by Steve Brandt. And they had over 2,000 complete patient records. And what they did was they separated L4 disease into very proximal disease in the esophagus, stomach, and duodenum, and in the jejunum. And they compared it to the L1 to L3 patients, and they also compared the two different upper GI diseases to themselves. And what they found was that the very proximal upper GI Crohn's disease tend to be diagnosed younger, with a shorter disease duration, less likelihood to be Hispanic in ethnicity, and a less need for abdominal surgery than L1 to L3 disease. As far as the jejunal disease, it's much less often associated with coexisting colonic disease. It was much more likely to have stricturing phenotype, and therefore less likely to have inflammatory phenotype, and also much more likely to require multiple abdominal surgeries. And if we compare the very proximal disease in the esophagus, stomach, and duodenum to the jejunal disease, what you see is that the very proximal disease is less likely to involve the ileum, much more likely to involve the colon, but much less likely to have a stricturing phenotype, therefore more likely to have an inflammatory phenotype, and much less likely to need multiple abdominal surgeries in the future. And on multivariable analysis, they identified that it was really the jejunal disease that had a 2 to 3-fold increased risk of stricturing disease or need for multiple abdominal surgeries. So what we think now is that perhaps this more aggressive phenotype with upper GI disease is really driven by the jejunal component and not the even further proximal disease. So for this talk, we're going to focus on Crohn's of the esophagus, stomach, and duodenum. And I want to first set the stage by delving into esophageal Crohn's disease more carefully, and we'll start with a case. As a patient of mine, 25-year-old woman with Crohn's of the distal ileum and pancolon who underwent a total proctocolectomy and ileostomy. She's on adalimumab, 40 milligrams every other week, and azathioprine. I do proactive therapeutic drug monitoring, as my buddy Adam over here does as well, and she had adalimumab levels greater than 5, therapeutic thiopurine levels. Her Crohn's disease clinically was in remission. Life had gotten in the way, and she hadn't been in for an endoscopy in quite a while. Then she acutely developed atypical chest pain and nausea, as well as some diarrhea, and importantly, she had no history of GERD or NSAID use. And this is her upper endoscopy. So this was done before I knew I needed to do a talk with videos, so therefore these are just pictures. But she had pan-esophageal severe ulceration, really, really horrible looking. She also ended up having some mild to moderate distal ileal ulceration as well. So she was having a flare in her ileum, but also newly in her esophagus. She'd never had esophageal disease before. So we'll get back to this case in a few moments. So there's a paucity of data on esophageal Crohn's disease. One of the largest series is from Indiana University, where they identified 81 patients from 1993 to 2009. And they found that only 36%, so about a third of patients had symptoms of upper GI symptoms, mostly nausea and vomiting, smattering with heartburn, and even less with dysphagia or chest pain. Diagnostically, they made sure to rule out GERD and NSAID use. And what they found on upper endoscopy was presence of aphthous or deep ulcers in about half of patients. On biopsy, all patients had lamina-propria chronic inflammation. Only 12% had granulomas. And the overwhelming majority of patients had disease outside of the esophagus as well, in both the stomach and or duodenum and the ileum and or colon. Fortunately, none of these patients developed a stricture or fistula. In the Mayo Clinic experience in the TNF era, this is from 1998 to 2012, they identified 24 patients who they thought had definite esophageal Crohn's disease. In this case, they had symptoms in the vast majority of patients. Many patients had dysphagia, odynophagia, epigastric pain, heartburn, or chest pain in a smaller percentage of patients. As far as where in the esophagus the involvement was, only 4% were proximal, about half were mid-esophageal disease, a quarter were distal, and a quarter was, as with my patient, panesophageal. 75%, so 3/4 of patients had inflammatory phenotype, the B1 phenotype, and on endoscopy they found superficial ulcers or erythema and erosions in half of patients. A smaller number of patients had deeper ulcers or pseudopolyps. A quarter of patients had strictures or fistula. On biopsy, the majority of patients had lamina-propria chronic inflammation, and 22% had granulomas. And only 13% had isolated esophageal disease. The others had ileal and or colonic disease. As far as treatment and outcome of these patients, so the 3/4 that had inflammatory disease, half were treated with prednisone, the vast majority went into remission and or response. 5 were treated with infliximab alone, all went into remission. 2 were treated with infliximab after prednisone, both of whom went into remission. 1 was treated with topical budesonide and went into remission. 1 refused treatment as she wanted to get pregnant. 4 patients had a stricture. 3 responded with a combination of dilation and anti-TNF therapy, with or without the combination of 6-MP and dapsone or budesonide gel. None of these required surgery, fortunately. 2 patients had fistula. 1 was an esophagogastric fistula who went into remission with a combination of infliximab and tacrolimus. 1 had a tracheoesophageal fistula who had no response to topical corticosteroids, stenting, or glue. As far as I'm concerned, if you need glue in your esophagus, you probably have some big problems. So back to my patient. So we increased her adalimumab to 40 milligrams weekly. We put her on high dose, twice daily PPI, and after 2 months, she was asymptomatic. Her levels increased nicely, and she's getting a repeat endoscopy next month, actually. So now let's turn to gastroduodenal Crohn's disease. So it most commonly involves the distal body or antrum and the duodenal bulb, and that's also where it turns out you find granulomas the most often. It's important to rule out H. pylori and NSAIDs here. Patients are often asymptomatic, but if they do have symptoms, they typically manifest abdominal pain, dyspepsia, nausea and or vomiting, anorexia, diarrhea, and weight loss. Less commonly, patients will present with strictures or obstruction. Pancreatitis if it involves the duodenum. Biliary colic if it involves the ampulla. And occasionally, you can actually even have a Linnitis-like picture which can mimic gastric cancer in patients that have actually undergone surgery for presumed gastric cancer, only to find out that this was, in fact, Crohn's disease of the stomach. Now, whenever we talk about gastritis, we have to talk about H. pylori because it's so common. Well, it turns out that H. pylori is more common in the non-IBD population than in the IBD population in a recent meta-analysis from University of Michigan. Conversely, HP-negative gastritis is relatively uncommon in the general population. So the problem with diagnosing gastric Crohn's disease is that you can see endoscopic and histologic changes in a good number of patients who have Crohn's disease, but that doesn't necessarily mean that they have gastric Crohn's disease. So changes you can see on endoscopy in Crohn's patients are erythema, edema, aphthous ulcerations or deep ulcerations, nodularity, polyps, bamboo joint-like appearance, which looks like this on the bottom, but I'll first show you. Is that a laser pointer? Anyway, so top left is some erythema on a patient of mine in the antrum. On the top right is some aphthous ulcerations there in the antrum. And on the bottom is a picture from a Japanese publication. So this bamboo joint-like appearance, which you can see sort of at 6 o'clock right below the scope, which has a pretty high specificity for Crohn's disease. And histologically, you can see changes in patients often that can be acute and or chronic and include crypt abscesses, lymphoid aggregates, ulceration, or granulomas. There's another entity you should be aware about. It's called focally enhanced gastritis, which is a purely microscopic lesion. It was defined by Oberhuber as having at least one foveolum surrounded by chronic inflammatory cells with or without neutrophils in a background of normal. What this looks like, this is on the left is high power view. You can see this predominance of chronic inflammatory cells, but where you really appreciate this lesion best is on low power. So on the right, this is a low power view with a stain for lymphocytes where you really appreciate the focality of the lesion. Now, in the 3 largest series that have looked at this in inflammatory bowel disease, while it's more common in patients with Crohn's disease, it can also be seen in patients with ulcerative colitis, and it can also be seen in patients without inflammatory bowel disease at all. And for this reason, it has a good but not great specificity for Crohn's disease. And it turns out this lesion is not associated with symptoms, CDAI scores, disease location, extent, or duration, or laboratory test results. So again, as the case with gastric disease, patients with Crohn's disease can also have endoscopic and or histological changes in their duodenum. That doesn't necessarily mean that they have Crohn's disease there. So they can have erythema, edema, erosions, aphthous or deep ulcers, granularity, a notch-like appearance, which looks like this. This is a patient of mine with Crohn's disease of the duodenum and also in the ileum and colon. And you can see she has these ulcers in her duodenum that have created a notch-like appearance. Histologically, you can again see acute and or chronic changes, which include villous atrophy, increased intraepithelial lymphocytes, ulceration, and granulomas. So then, how do we diagnose Crohn's disease of the stomach and duodenum, which can be a little bit tricky? So first of all, I just want to mention that upper endoscopy with biopsy is recommended from some societies for the workup of all IBD in pediatrics or the workup of all Crohn's disease in adults. The reason being that you can identify upper GI granulomas in 12 to 28% of patients who have inflammatory bowel disease, therefore making a diagnosis of Crohn's disease. Unfortunately, though, because these upper findings are so common, the really significance of doing an upper endoscopy in patients without upper GI symptoms is a little bit unclear, and therefore some actually advocate reserving the use of upper endoscopy for patients with established Crohn's disease who now have upper GI symptoms, or in patients with IBD unclassified to help differentiate between Crohn's and ulcerative colitis. From my reading and experience, the best diagnostic criteria I've found to diagnose gastroduodenal Crohn's disease on upper endoscopy endoscopically is the presence of erosions, ulcers, cobblestone-like appearance, stricturing, a bamboo joint-like appearance that you can see in the stomach, or a notch-like appearance that you can see in the duodenum. And on biopsies, by far the best diagnostic criterion is the presence of epithelioid, true Crohn's granulomas, which, to remind you, is this. So the true Crohn's granuloma is an epithelioid granuloma, which is comprised of at least 5 epithelioid cells. And epithelioid cells are activated histiocytes with homogeneous eosinophilic cytoplasm. It can be with or without the presence of multinucleated giant cells, but importantly, there's an absence of caseating necrosis or foreign body reaction, and it's also not associated with an ulcer bed or ruptured crypt when you see crypts down further in the bowel. So as far as the treatment of gastroduodenal Crohn's disease, not surprisingly because it's relatively uncommon, there's a paucity of data. While PPIs can help suppress acids and help symptoms, they don't actually alter the natural history of the disease, and therefore you have to treat like Crohn's disease elsewhere in the bowel, i.e. with immunosuppressive therapy. It may, though, in fact, have a better response rate than Crohn's disease elsewhere, unlike the jejunal disease. With patients with strictures in the stomach, typically in the pylorus or in the duodenum, we can do endoscopic dilation, which I'll show you in just a moment. And for some patients, they end up requiring surgery. And as far as surgery, the 2 most common modalities used today are strictureplasty and bypass. Strictureplasty obviously has the advantage of preserving bowel, and compared to bypass, may have a lower risk of future dumping syndrome, peptic ulcer formation, bile reflux, gastritis, anastomotic leak, or gastric outlet obstruction. But it may have a higher risk of wound or intra-abdominal infection, primary failure, stricture recurrence, or reoperation. So it's really, strictureplasty is best suited for short strictures with limited edema and patients with a short bowel. As far as bypass, the 3 most common approaches used are gastrojejunostomy, duodenojejunostomy, and gastroduodenostomy. And the laparoscopic approach is associated with a lower risk of complications and a faster recovery with a shorter length of hospital stay versus the open approach. So now let's look at some cases of gastric and duodenal Crohn's disease. So this is a patient of mine with gastric Crohn's disease. She's 49. Her duodenal and colonic disease has been quiescent. She also has IBD-related arthritis. She was intolerant to thiopurines. Adalimumab had caused some injection site reaction. And then she had good response to infliximab, but had loss of response with high titer antibodies 2 months later. And then when I saw her, for the first time, she was on methotrexate, which was having a little bit of benefit. So I added certolizumab pegol, and she had loss of response despite off-label dose escalation to 400 milligrams every other week. So then I switched her to ustekinumab, and she again had no benefit, even despite increase to off-label 90 milligrams every 4 weeks. I pretty much live in an off-label world, just to let you know. And she's been largely prednisone dependent. So this is her endoscopy. So this is her antrum. She has multiple ulcers, one of which is enormous with a big clot on it. She was actually surprisingly not surprisingly iron deficient anemic as well. So she has really terrible disease here, which was causing her a lot of symptoms. I subsequently have just switched her to vedolizumab and continue her methotrexate, so we'll see how she does. So for duodenal Crohn's disease, is another patient of mine, 22-year-old male, ileal Crohn's disease, status post-ileosarcectomy after loss of response to infliximab. I saw him for the first time 2 years later when he was on adalimumab, 40 milligrams every other week. But he recently had been having some right mid-abdominal pain, some nausea, and a 10-pound weight loss. And on endoscopy, he had multiple ulcers in his second through fourth part of his duodenum. So at that point, I checked his adalimumab levels, and there were none, and he had high titer antibody. This is in nanograms per milliliter for the antibodies. So I changed him to certolizumab pegol in combination with methotrexate. Shortly thereafter, off-label increased his certolizumab pegol. He stopped methotrexate on his own due to side effects of nausea and fatigue. And at which point, about a month or so later, when I saw him, I added azathioprine. And 6 months after starting the certolizumab pegol, he felt worse with more abdominal pain and weight loss. And this is his endoscopy then. So larger, more extensive, deeper ulcers. Looks pretty nasty in the second through fourth part of his duodenum. So at that point, I changed his certolizumab pegol to vedolizumab. I continued his azathioprine. I also put him on a two-month course of prednisone starting at 40 milligrams a day, which helped him a little bit, but not a lot. His thiopurine levels were therapeutic. And finally, actually 4 months after starting vedolizumab, he actually noticeably felt an improvement in his symptoms. And this is his endoscopy 6 months after starting vedolizumab. And as you can see, he only had 3 really small ulcers in his duodenum. He had evidence of scarring on the top left. And on the bottom right, he had really nice evidence of a healing of an ulcer, so really nice improvement. And this is another year later, endoscopically completely normal, which was a fortunate result for him. So now let's end by talking about endoscopic stricture dilation. This is data from the Cleveland Clinic, many of which these dilations were done by our good friend Bo Shen, who will be talking to you shortly. In addition to pouches, Bo knows strictures. So Bo knows a lot about a lot of things, as it turns out. So they identified 35 patients with Crohn's disease who underwent 96 endoscopic dilations. A third of them were in the stomach, in the pyloric region, and about 2/3 were in the duodenum. And high rates of technical success, regardless of location. Low rates of complication, being mostly due to bleeding, very low rates of perforation. About 50% or more needed redilation, more commonly in the pyloric region than in the duodenum, after about a median of 2 to 3 months. And a third of patients ultimately required surgery. And if you delve a little bit more into the idea of the repeat dilation. So first dilation had a very high technical success and clinical success by resolution of symptoms, but about half needed redilation. About a month and a half later, again, high success rate, and about 50% need redilation. About another month and a half later, again, a high success rate, but a lot need redilation. So you see a pattern here. These patients often will need redilation until their medicines really start healing the disease better. And they did not identify any factor which is associated with short-term efficacy or time to redilation. So I just want to end with a few videos of a patient of mine who had gastric Crohn's disease with pyloric narrowing, who I dilated. So this is her third endoscopy with dilation in 5 months. So she had her second dilation 2 months after the first, and her third dilation 3 months after the second. And as you can see here, she has some narrowing in her pylorus, which I was actually able to finally get through on this scope. Her second and third scope I was able to get through with the scope before dilating her. And then this is her dilation. You've seen this many times on your own. And this is the after. So the first time I dilated her with 9 to 12 millimeter balloons, and the second and third time I dilated her with 12 to 15 millimeter balloons. And her symptoms were indigestion, really inability to tolerate solid food. And she had some retained gastric contents food in her belly. And you can see here we get through. And then when we come back and look again, you'll see that the inflammatory tissue here was creating part of the narrowing that was causing the problems. And here we're going back in. Big ulcer here in her antrum, and then here So you can see here that right in the middle of the screen, this inflammatory tissue that had caused part of the problems, and we get through again. Okay, thank you very much.